All right.
Okay, thanks.
Let's
Thanks for
too
the
annoying to people. No problem. Go
again,
ahead.
thanks for the opportunity. Let's just go with it. So, HIV, the burden is increasing globally, although with vaccinations, great strides have been made in bringing down the prevalence worldwide, also in South Africa. But due to other public health prominence kind of HIV, TB, malaria, hepatitis B has kind of fallen off the radar. I can still remember my first international congress that I went to I think it was in the early 2000s and in Portugal. And there was a talk on the treatment of hepatitis B and the new potential drug of tenofovir. And a vaccinologist came up to the group afterwards while we were chatting about the talk. And he said that he doesn't know why people are still considering treatment options and spending money on this when we do have an effective vaccine available, because it's a disease that's going to disappear in the next decade or two. Obviously, that has been proven to be wrong, and we have an increasing prevalence. So I'm just quickly going to say something about the unique epidemiology of hepatitis B in our environment. Say something about the diagnostic approaches currently recommended. Give you a general overview of how to approach the treatment of hepatitis B, chronic hepatitis B, and then just highlight a few clinical scenarios that may warrant a few special considerations, including infection in healthcare workers, pregnancy, HIV, Hep C, and Hep D co-infection. And if we do have time, I've got a couple of cases that we can go through. I must confess, most of the slides that I'm going to show you, I've just pulled out of the PG-DIP infectious diseases that we are presenting here at Stellenbosch, and just a plug-in for that as well. We are full for 2026, but if you are interested in this diploma, please contact me and we can look at maybe 2027. The best current guideline, most up-to-date, and the best reading I could really find is the new WHO guidelines for the management of hepatitis B and the prevention, diagnosis, care in general. Just a couple of highlights from this guideline that I'm going to say more about in the presentation is that it has simplified the treatment criteria for treatment in adults and adolescents older than 12 years, and it's also expanded the potential categories of people that can be treated. It has also expanded the eligibility for antiviral prophylaxis in pregnant women to prevent vertical transmission. And there's also a few things on improved HPV diagnostics, especially point of care testing, and also the concept of reflex approaches to viral load testing if you do have a positive HBs antigen. Many people that has chronic HPV infection across the world, as you can see there, and the majority of those people are in African and Western Pacific WHO regions. But it must be said that I think hepatitis B is one of those conditions that differs most with regards to gender, ethnicity, rural versus urban prevalence, and also among countries and within countries. You can see it's quite a scattered prevalence chart here, and also in Africa, the general information is that the highest prevalence is in men and boys born in poor rural areas, where classically there's the least kind of options available for testing and treatment for these people. In South Africa, we have an intermediate endemicity, and it has come down successfully over the last decade or two due to vaccinations. And you can see there we are at 4.6% at the lower end of intermediate endemicity. The problem of HPV, however, that it is a silent and currently still incurable disease. In Africa and Asian countries, chronic HPV is established in early childhood, mostly perinatal transmission. And then liver damage occurs over decades, and people only present in early and mid-adulthood. The other problem is that it's still a leading cause of chronic liver damage. As you can see there, 2.5 million South Africans, in spite of a safe and effective vaccine since 1982, and in South Africa introduced in 1995. So for 30 years, we've had an effective vaccine available. This is also compounded by the high prevalence of co-infections in our region, including HIV specifically in South Africa, but also in Africa in general, especially the northern hemisphere of Africa, HDV infection, and also compounded by the increasing metabolic risk factors that we see and alcohol use. So all of these things play a role in hepatitis B being still the main role player in chronic liver disease in our environment. Transmission we all know about, just to note that is also transmitted via saliva. And the 5 scenarios of transmission is perinatal transmission, child-to-child transmission in early childhood, sexual transmission, percutaneous transmission, and blood product transmission. The main routes of transmission in Africa, as I've alluded to, is perinatal and child-to-child transmission before the age of 5 years of old. And the interesting thing about the epidemiology is that if you are infected perinatally or from mother to child, it's a 95% chance of developing chronic hepatitis B. And as time goes on with regards to infection, over time, the older you get, the lower the risk becomes for chronic hepatitis B persisting. If it's before the age of 5, there's a 30 to 50% chance of developing chronic hepatitis B. And as you can see there, as an adolescent, it comes down to 6 to 10% and even lower with regards to exposure and infection in adulthood. With regards to the diagnosis, it is estimated that only 2% of people with hepatitis B actually do know their hepatitis B status. And one of the reasons is because of the limited access to affordable diagnostics in the areas where hepatitis B is very prevalent. And especially with regards to determining treatment eligibility, hepatitis B PCR testing, viral load testing is quite expensive, and it does cost more than 1 year of TDF treatment for a patient. So emerging is the point of care testing, which is quite good. It is it has all the criteria for specificity and sensitivity, especially in high burden environments. So HPS antigen point of care testing is currently recommended, especially in a primary care environment where laboratories are not close. And those are very valuable in identifying your patients and also linking them to proper care. And still not available as far as I know in South Africa, but it's also the hepatitis B DNA point of care testing. And some studies that I have seen have shown a turnaround time of anything between a couple of hours to a day for proper results, which takes away that whole issue of people coming back for results, getting lost to follow up, and leaving the system because they have to come back for results. So you can immediately make a proper diagnosis, also determine based on DNA criteria for treatment eligibility, and start treatment on the same day or very soon after. And then there's also emerging tests available like hepatitis B core-related antigen, also a point of care test. It's a surrogate for high hepatitis B viral load, more than 200,000. And it's got a really good sensitivity and specificity for that as well. But as far as I know, not commercially used in most places. So recommendations, the WHO recommends that any country with a intermediate or high endemicity of hepatitis B, including a place like South Africa, should try to have universal testing, which is obviously not possible in general context because of costs involved and also in terms of priority of spending. So I would say in South Africa, if you look at how the disease is transmitted, if we're looking at preventing future infections and eradicating the disease, the most important group to test would be pregnant women. And all pregnant women should have an hepatitis, should have an HBs antigen test done as early as possible in pregnancy. Other key populations that may benefit, also important, and then obviously anybody with an unexplained raised ALT or AST should also be tested. These other key populations can include the following, and I think also very important and often missed are the contacts of people that we already know are positive, close household members, sexual contacts, etc. Should be prioritized. Also healthcare workers who should also be tested, especially if they have not been vaccinated before. With regards to treatment, there are basically 4 criteria that are considered when we consider the treatment of hepatitis B, and usually in combination. It's a severity of liver disease, which is usually based on the assessment of fibrosis, and we'll go a little bit more deeper into the assessment of fibrosis. The host risk for progression or reactivation, and then the viral load, and then the ALT levels. Those four parameters are generally used to determine eligibility for treatment. Treatment would be with tenofovir as a single drug, which is enough, but if cheaper, one can use also a combination of tenofovir and 3TC, depending on the country that you are working in. We know that treatment prevents and reverses certain levels of liver fibrosis. It reduces the incidence of cancer. In general, it increases or improves the quality of life, reduced onward transmission of hepatitis B. It is cheap, it is safe, also robust with regards to hepatitis B resistance developing, and obviously also it can act as a PrEP as well for patients that are on treatment and who are HIV negative. So what are the tools available to us to assess fibrosis? Liver biopsy is invasive and not recommended anymore as a routine assessment for patients with chronic hepatitis B. So FibroScan is the best tool to use currently, non-invasive tool, but it is quite expensive and not available widely, and especially not available in primary care and secondary care environments. And then you can use an API score or other scores like the FIB-4 score. WHO recommends using the API score, the AST elevation over the platelet counts times 100. A low API score has got a good negative predictive value, while a higher API score, more than 2, it's got a greater positive predictive value for cirrhosis. In between, it is less accurate and less valuable in using. So this is, I've mentioned this is how you do it. The AST elevation is the AST divided by the upper limit of normal for your laboratory, and then divided by the platelet count and multiplied by 100. And yeah, that is just the basic, easy to do, and it should be done in all people with chronic hepatitis B infection. The AST is used rather than the ALT. And the reason for that is because the AST is a more consistent marker for underlying fibrosis and cirrhosis compared to the ALT. The AST is also prevalent in the mitochondria, not only in the cytosol of the hepatocytes. With advanced cirrhosis, you can get your ALT, which is mainly cytosol, in the cytosol, to actually remain normal or actually also decrease. So the ALT not a very consistent and reliable finding for liver fibrosis and cirrhosis. Therefore, the AST and the platelet count, especially in more advanced portal hypertension and splenic sequestration, the platelet count will drop and be a sign of underlying portal hypertension and liver cirrhosis. I'm trying to go, there we go. Sorry for the small print there, but this is just a graph to show you the specificity and the sensitivity of different API score outcomes. And in previous iterations of the WHO guidelines, API of more than 2 which is very specific for liver cirrhosis and fibrosis, was recommended as a non-invasive criteria for starting treatment. Subsequently, it was found to be not sensitive enough, and it has been adjusted. Other studies have shown 0.65 to be adequate, others 0.5, and that's why currently the WHO recommends an API score of more than 0.5. So the problem is, and I think where all the problems comes in with regards to the rollout of treatment criteria, understanding how it works, and the complication is that over the years, there's been several attempts made to find the right balance between treating people at risk for developing the complications versus not treating the people that are probably going to be okay for life and die with their infection, but not from their infection. Unfortunately, all of these criteria used has created a massive treatment gap. And this is before the most recent WHO guidelines. It was found that 19% of people with the old guidelines met the treatment criteria, but only 0.1% of those people were on treatment, which meant that there was a treatment gap of about 15.5 million people who should have been on treatment but were not on treatment. Many reasons for that, which we can explore now. So the limitations were, and this is something that we found as part of a collaborative research group, HepSaNet, is that certain categories of individuals who are not eligible according to the older guidelines still develop cirrhosis and hepatocellular carcinoma. In our cohort, 11.8% who were HBe antigen negative, meaning that they should have a lower viral load, actually had HBV DNA loads of more than 2,000. But they had normal ALTs. So with regards to the older criteria, they did not qualify for treatment, but probably would have benefited from treatment. Also, most of our understanding of the natural history and the progression of disease is derived from the Western Pacific regions, where other genotypes are predominant compared to the genotypes prevalent in the African setting. There may be also inherent genetic determinants of immune control, etc., that may not be relevant to our environment, and we may also have increased exposures to other immune modulating conditions, including HIV, ailments, etc., malaria included. And then also in Gambia, there was a study done to show that many people were not eligible according to their criteria. Less than 10% had eligibility. This then led to people that needed to be followed up more chronically, needing monitoring that cost money potentially, and it led to a significant loss to follow-up. And I think something that hepatitis B has in common with our current understanding of HIV is also the significant loss to follow-up and loss to the care system overall. Sorry, I've got difficulty progressing. There you go. So just before we go on to the approach to how we should approach the treatment, remember this, the 4 phases of hepatitis B: persistence and reactivation. You all know this. This is another reason for the complications and the difficulty understanding chronic hepatitis B, is because this graph, although it looks linear, it specifically is not linear, and the one does not follow onto the other. All of these phases also do not necessarily need to occur, and it does not include all the permutations of how the disease progresses. So again, part of the complication. So here we have your immune tolerant phase and your immune clearance phase, both of those being HBe antigen positive, and then your HBe antigen negative immune control phase and immune escape phases, including to that the risk of reactivation, what does occult infection mean, and what is the risk for reactivation in patients with occult infection, and so on. So this is really a complicated disease to understand, and I think much of this spilled over into our understanding of how to try and treat this condition. just the same slide again. So basically the old guidelines are still very much the current guidelines as well. You would look at those two, the immune tolerant and immune control phases, where you can see that your HPV DNA, or not your HPV DNA rather, but your ALT is probably low. Your HBs antigen is coming down over time. And these were the two groups that were not recommended for treatment. While your immune clearance phase and your immune escape phase were your more your phases where there was a little bit more increase in risk for viral replication, for liver necrosis happening. And those two groups were mainly the two groups that where you needed initiation of treatment. But for that, you needed to be able to assess the HPV DNA. You need to have regular ALT levels being done, and also have an understanding of your E antigen status. Okay, so that's the baseline on top of what I'm going to now kind of try and give you a basic approach to the treatment of hepatitis B. So firstly, and very importantly, I think we often do not spend enough time examining our patients, getting good history from our patients. It's very important to determine family history of underlyings of previous cirrhosis or hepatocellular carcinoma, because that's a very high risk for people to continue to develop early complications. Also to determine where your patient falls into. Does he have uncomplicated hepatitis? Is there current acute fulminant liver failure present, or does he have features of liver cirrhosis, portal hypertension, hepatocellular carcinoma being present? So a good clinical evaluation of your patient is very important from the first day on. With regards to your liver function tests, the most important there would be your ALT to determine the degree of necroinflammation. You would have your other HPV markers to complete your HPV serology if you can, to see if the patient falls into the E antigen negative or E antigen positive categories. Also, if available, you can do your HPV DNA levels, as those are very important to determine eligibility, and it's a very good marker of ongoing viral replication and risk for complications developing over time. Also then, the fourth thing that you want to determine is your non-invasive markers for fibrosis. We've mentioned the API score and the FibroScan being the main ones. You can also use other scores like the FIB4. And then very important not to forget about the viral co-infections, which I'll say something a little bit later on about. So those are the 5 things that you want to look at when you see a patient with hepatitis B. If you don't have access to many of these things, I think the bare minimum for this would be to, again, your clinical data and your ALT, very important and usually available everywhere. But otherwise, your non-invasive marker, you can only use your API score. If you don't have a FibroScan, it's fine. And also in terms of viral co-infections, if you can't test for the others, HIV is the most important one in our environment. So with these criteria and assessments, you can make a confident decision on whether you want to treat somebody with hepatitis B. Adding to that, obviously, also pregnancy. Sorry, I left that one out. Pregnancy should also be in there. Okay, so the WHO then came out with the expanded eligibility for treatment guidelines, and this is just a quick summary of what they recommend. There's 4 options for treatment eligibility. So you treat all people with significant fibrosis, irrespective of their DNA or ALT levels. And this is based on revised thresholds for your non-invasive testing. So an API score of more than 0.5 or a FibroScan of more than 7 kilopascals is adequate indication on its own for the treatment of all patients with chronic hepatitis B infection. It is estimated that with using that criteria, 20 to 25% more people with chronic hepatitis B will start with treatment, or will have the criteria for starting. If you do have viral load testing available, all patients with a HPV DNA of more than 2,000 international units and ALTs above the upper limit of normal for your laboratory would be candidates for treatment. Usually, there was a distinction between E antigen positive and E antigen negative patients. It was more than 2,000 in your E antigen negative patients compared to more than 20,000 in your E antigen positive patients, which again brought in unnecessary complications into deciding on treatment. So now it's all people with a viral load of more than 2,000 and increased ALT levels. Again, up to 25% more people would be eligible for treatment if this criteria is used. And then regardless of your viral load or your ALT levels, if people have co-infections, they've got a family history of liver cancer or cirrhosis, they've got immunosuppression, or they have other comorbidities putting them at risk of progression, they should also be started on treatment. Again, up to 20% more people would start treatment if this criteria is used. And lastly, if you don't have access to hepatitis B viral loads, one should treat all of those with persistently abnormal ALT levels on their own. So if you have ALT levels that's persistently elevated over a period of 3 to 6 months, then these people should also be started on treatment. That's your criteria, and as you can see, it's much more simplified. I think there's still some work to be done on the first one, where we're looking at the HAPI score, because there's some emerging data that shows that we should maybe not use an increased HAPI score in terms of specificity for cirrhosis, but rather use an exclusion criteria, a more sensitive test, to say that everybody below a certain HAPI score should not be treated and everybody else should be treated. But for now, this is what we have, and I think a great improvement on the treatment criteria that we had before this. What about prevention and the elimination of hepatitis B? One should obviously try to prevent transmission through vaccination. Birth dose vaccination is currently recommended, also part of the South African guidelines, within 24 hours after birth. And important, and I think one of the things that may be a problem in South Africa, especially in the more rural environments, is to complete the 3-dose schedule to prevent a later transmission after birth. And then also antenatal HBS screening and treatment should be done in all pregnant women. I don't think HBS antigen screening is currently part of our guideline in all pregnant women, but I think it should be done anyway. So with regards to this, only 30% of countries in Africa have policies for universal birth dose vaccination, and less than 10% of Africans do receive it. So a major gap in prevention cascade. And then also it is estimated that if one can increase your birth dose vaccination to around 90% of newborns by 2030, one can prevent more than 700,000 deaths in that specific birth cohort going forward. And then lastly, with regards to antenatal screening and treatment, less than 1% of pregnant women in Africa are currently screened and treated for prevention of vertical transmission. So again, a major gap in our prevention cascade. Okay, so with regards to, I'm going to say a little bit more about pregnancy now, but just quickly with regards to the healthcare worker, one should first determine in general, as we've just discussed, is there any indication for treatment in general, and then follow those guidelines. But also, will the person be performing exposure-prone procedures? Are they dentists, surgeons? Are you going to put in a lot of lines? Are you going to be exposed to patient blood, etc.? And then, if so, it's important to know that you want to know what the viral load is. A viral load of more than 200 is considered an increased risk of transmission to your patients, and that should be known. So, and a patient should be treated if the viral load is more than that, irrespective of the other criteria for treatment. Your goal would be to get below 200 before a person returns to treatment exposure-prone procedures. So in general, then, that's the only criteria. HPV infection does not disqualify healthcare workers from surgical, dentistry, medical, and other allied health fields, and should be encouraged to continue with their work. Okay, with regards to pregnancy, in general, it doesn't look like pregnancy in patients of hepatitis B that is more severe liver disease in the majority of women. There are case reports indicating that there may be increased HPV reactivation, hepatitis flares with fulminant liver failure developing, but there's no conclusive evidence for this. Also, there are case reports showing higher rates of preterm births, lower APGAR scores, gestational diabetes, and antepartum hemorrhage. So in general, it is recommended that patients, pregnant patients with hepatitis B, chronic hepatitis B infection, should be followed up carefully to look for these complications developing. With regards to testing, I have mentioned that all people should be tested if they are pregnant, preferably as soon as possible after pregnancy, within the first trimester. If they are negative, they should be vaccinated if the vaccination is safe in pregnancy. And obviously, if they're positive, they will need additional testing, counseling, and then obviously then one should consider potential prophylaxis for vertical transmission. What about the pregnant woman developing acute hepatitis B infection? In general, treatment is also not recommended unless a patient is in liver failure. But one should keep in mind that acute infection usually goes with very high viral loads that may increase your risk for vertical transmission. So in general, it would say if a patient develops acute hepatitis B in the second and third trimester, the premise is that there's not enough time for these patients to develop natural immunity for the HPV to come down naturally, and they should be treated. And also, if they've got very high viral loads, more than 200,000 in the third trimester, it's also recommended to give them treatment, prophylaxis for preventing transmission to the baby. With regards to chronic HPV in pregnancy, the current recommendations say that pregnant women with chronic hepatitis B who has a viral load of more than 200,000, or if you don't have viral load available, if they are HBe antigen positive. HBe antigen is a reasonably good surrogate for your viral load. But if you don't have either one of those two tests available, it is recommended with low certainty and by the WHO that all pregnant women who are HBe antigen positive should receive prophylaxis for transmission in intermediate and high immunity countries, which will include South Africa. Regards to the mother, tenofovir is the preferred agent. One should start from the second trimester, that's the current recommendation, and one can stop either at delivery or completion of the infant vaccination schedule. One just need to make sure that the mother does not need chronic therapy for her own health. Also, it's also recommended that if the patient is planning more pregnancies in the near future, there's also the option to continue with treatment right through. And then lastly, obviously check your HIV status, because HIV, as we all know, is an indication for treatment of both conditions. With regards to the neonate, the birth dose vaccination is very important. It's not recommended to do C-sections for the prevention. And also breastfeeding is not contraindicated. In general, HPV is not transmitted through breast milk, but one needs to take into consideration the risk involved with bleeding or cracked nipples that may hold an increased risk for transmission, especially if the mother's viral load is not suppressed. Okay. So with regards to HIV, we know that the liver-related mortality is quite high. And there's an increased risk of perinatal HPV transmission in HIV positive patients. There's an increased risk of liver disease. There's an increased likelihood of chronic hepatitis B developing, and also increased likelihood of long-term HBe antigen positivity as well. There's also increased risk of occult hepatitis B, and an increased risk of cancer at a younger age, and also more aggressive disease developing. And as we all know very acutely, is that there's an increased risk of drug-induced liver injury in HIV positive patients, which adds another layer to the complexity. When we do treat patients, we know that the outcomes after 5 years, and this is a study looking at TEE, is comparable to patients who are HIV negative with high rates of suppression. HBe antigen loss occurs in up to almost 50% of patients, and S antigen loss very low at 12%. And there's no other issues with regards to it, except that there's a lower but persistent risk of hepatocellular carcinoma remaining in HIV co-infected patients. It's recommended to use the most potent anti-HPV drug. It's also potent against HIV, and as we all know, that lamivudine, although very good for HIV, it's not a great agent for the treatment of hepatitis B as a single agent, because of its lower threshold for resistance developing over time. And Entecavir can be used quite good, but remember that it doesn't have very good HIV activity, and it should be an add-on to your ARV treatment. There's also a potential risk of increased iris-related hepatitis B flares. If that happens, a potentially higher rate of hepatic decompensation developing. So that's why all your regimens must have a very effective treatment regimen in that includes tenofovir. This has been shown to be more prevalent in regimens excluding tenofovir. This can happen with ART discontinuation, and therefore the reminder to include your tenofovir also in cases where you are going to stop it for your HIV treatment, to continue with it in your for the treatment of hepatitis B, as we all know. What about this concept of HIV hepatitis B viral load discordance? So we do find, not uncommonly, that very often if you follow these patients up in your HIV clinic, you find that the HIV viral load is suppressed on the TLD, but the HBV viral load is not suppressed. Now, the main reason for this is the HIV reservoir. And according to my virology friends that explained this to me, is we find the HIV reservoir, the biggest part of it is actually in the CD4 cells. A very small part of the HIV reservoir is outside of the CD4 cells. These are high turnover, fast decaying cells compared to the hepatitis B infecting the hepatocytes, which are slow decaying cells present for a longer time, and therefore shedding wild-type virus more continuously. Also, one of the reasons why resistance is more or less likely in hepatitis B is because of the wild-type persisting in spite of a potential resistant genotypes being present. So this is the main reason. So one can expect slower hepatitis B viral load suppression, and its acceptable decrease would be more than 1 log reduction over a 3-month period or 6 months, depending on when you're going to do it. It depends very much on the baseline viral load, and we've seen cases that can take more than a year to become lower than detectable level. So it can take time. As long as it comes down, if there's a downward trend, you're not concerned about any other problems developing. Other causes that needs to be ruled out is, especially if your INSTI-based regimens, intermittent adherence can result in proper HIV suppression, but may not be enough for hepatitis B suppression. If a patient, in the rare occasions of a patient who is an elite controller that you're not aware of, have poor adherence to the treatment, they may still have an undetectable HIV viral load, but will have a very high hepatitis B viral load. And then very rare is true resistance developing, and very little data available on this and the clinical relevance of resistant genotypes. With regards to hepatitis C, just quickly, we see that there's more severe disease, faster progression. Hepatitis C is the dominant driver of inflammation. And one usually sees the HBV DNA levels being relatively low. But one need to remember that if you do treat your hepatitis C with your DAAs, that it can result in hepatitis B reactivation, either during or after hepatitis C clearance. And therefore, it is recommended to first treat your hepatitis B, and if your DNA levels are suppressed, to start hepatitis C treatment. You can continue hepatitis B treatment for up to 12 weeks post-hepatitis C therapy, unless the person needs chronic B treatment, obviously. And then just quickly, hepatitis D co-infection, also more aggressive disease course, but one needs to remember that the seroprevalences of hepatitis D varies geographically, especially in the African continent, and in all countries in the southern hemisphere that have very low seroprevalence of hepatitis D and very unlikely to occur, while it's a different story in the more northern countries. So if you do see patients from these other countries, you can consider testing for hepatitis D as well. Okay, I don't think we need to go on to the cases now. That's kind of straightforward, Jeremy. I think we can stop here. And maybe I can rather take some questions.
Okay, that sounds good. That's really fantastic. Thank you, Jantjie. Incredible overview. I mean, I've learned a bunch. It's slightly alarming when you've treated them, and clearly I've made some mistakes that I need to correct. So thank you very much. So going through some of the questions, there's, I guess, the kind of eternal question about someone who's got no surface antibodies, maybe with a history of being vaccinated, like a healthcare worker who went through and got vaccinated in med school, but then they check the antibodies and they're negative. Or someone who maybe doesn't have a history at all of vaccination. So what would you suggest if they're not otherwise high-risk individuals?
Sorry, the question is just being
Sorry,
less antigen negative.
Maybe two scenarios. So one is a healthcare worker who I guess is high risk of acquisition because of the patients they deal with, but who has been vaccinated but has no surface antibodies when they check,
Okay.
so to speak. And then the other scenario is someone else who's not high risk but happens to have no surface antibodies. Would you vaccinate everyone, or what would you suggest?
So the healthcare worker, definitely, if they've got low antibody levels, and the guideline says less than 10, it's still some experts would say the antibodies is not really a good way of determining immunity, because there's still some cellular immunity that may be present and immune memory. But currently the guideline is 10. So if your antibody titer is more than 10, you're okay. Less than 10, you need a booster. So that's currently the guideline. So, and I think that's something that one should adhere to for the time being. With regards to anybody else that do test themselves and they have not been exposed to hepatitis B, I would think that it depends on your risk for becoming infected as an adult. So depending on your risk profile, would you fall into a key population? Are you going to work with people who may be infected, etc., and then determine whether you want hepatitis B vaccination or not?
Yeah, that makes sense. I was delighted to see they've dropped the e-antigen story. It's been a bugbear of mine for many years. It's a pointless test.
Me too.
But that's really good. So message out to everyone, please. No e-antigens anymore. And then another very good question in the chat asking about what if tenofovir is contraindicated, for example, in CKD? Are there any other options you'd suggest?
Yes. So obviously one can go to TAF for those patients with renal impairment, or even patients with advanced osteoporosis. You would probably not try TDF, but you can go to TAF. But again, that's also not you can go to lower eGFRs, but not in advanced kind of very low eGFRs. Even TAF is not acceptable. The other recommendation is entecavir, but that's also limited with regards to renal impairment. One can give alternative dosing. That's one option. So alternative day dosing in patients. Yes. Did you say something, Jeremy?
No, go ahead.
Yeah, you can give alternative day dosing, or if it's really not established CKD, and you can expect some improvement. Lamivudine is really a good hepatitis B drug on the short to medium term. It takes time to develop resistance against. So I would think if you expect reasonable recovery of renal function over a 3 to 6 month period, lamivudine is adequate treatment for patients that will recover the renal function.
Yeah, that's a great point. And then someone who's in the chat was just wondering if TAF is Section 21, so it's not anymore. It's registered in the country.
Not anymore, yeah. No, it's available now, but I think it should be used judiciously. And I think the main reason why we use it in our environment is basically for that group of patients with very low GFRs. But again, as soon as it goes below 30, maybe other people on the group can add more value to this discussion. But as soon as it goes below 30, I think also even TAF is not indicated as a daily dose.
Yeah. So the TAF one is weird because it's registered if it's with 3TC or FTC rather, usually, because that's where then it stops at 30, and that's because they're worried about the FTC. It's weirdly, and with TAF it can go all the way down to 15 or hemodialysis, but not less than 15 if you're not on hemodialysis. So it's a really kind of complicated mess. But I do think it's worth thinking about because sometimes people, let's say your GFR is 20. It's not the TAF we're worried about, it's actually the FTC, but we know that the FTC is really well tolerated. So even though the guidelines will always stick with it, it's worth at least considering pushing it in some big people, at least, if there's no other good option. There's some
that's a good insight.
really fantastic questions on the chat, so I'm just going to go through as many of them as we can. So Narcissus Pumble, who's obviously our pediatrician ID expert, saying that we don't currently do routine hepatitis B vaccination at birth. Obviously, it's targeted, so if the mom is positive, obviously they recommend the birth dose, but not routinely. And she's wondering what you think about reconsidering that, especially considering we don't routinely screen all pregnant women for hepatitis B.
Yeah, it's a major problem. I think our hepatitis B guidelines do include it, the national guideline. Do include birth dose vaccination, but I think there are many issues here. I mean, if you're not going to test anybody, I agree. I mean, where does it? The two needs to kind of be congruent. I don't think we should care very much about the guidelines. Sorry for being a little bit difficult here, but I think all pregnant women deserves a hepatitis B test, and then adequate management. With regards to the birth dose vaccination, it does bring in a lot of more complexity with regards to bringing the patients back for their follow-up test vaccination, because it's a series of 3 vaccinations, and to make that fit in with all the other vaccinations. So there are some organizational and logistic issues with regards to, after your first birth dose, how to then stagger the follow-ups, not to make it more difficult for the patient. But I think it should be there if it's possible to do, and especially if the mother is HPV positive, it should be done. So I think everybody must be tested, at least. Then if they do have the criteria to go on to prophylactic treatment, which is available and cheap. And then the next problem would be the birth dose vaccine. But if we can bring down the viral load in the mother when she gives birth, the birth dose vaccine may be less important, I would argue, while we are still trying to figure out to get that birth dose vaccine in. But it's a combination of interventions, and I think any one of them, if we can include them, are better than not doing any of them just because one is difficult.
Yeah, no, agreed. And then another tough question about so someone who's HIV co-infected with hepatitis B, is there any endpoint ever? In other words, is there should anyone be, like, maybe after 5 years checking a surface antigen or something and deciding if they can stop the tenofovir, or is the current recommendation just lifelong tenofovir regardless? This is in the HIV co-infected individuals.
I think the easiest one is to give lifelong, but I think there is complexities here, because people who do actually seroconvert their S antigen We know that hepatitis B is not curable, so they are still infected, and they probably have an increased risk of occult infection. And we do know that there is an increased risk of reactivation as well in people where you stop treatment, especially in HIV positive patients, but also in general. So there remains an increased risk of reactivation, even in people who do have a surface antigen seroconversion. But I think in certain individuals, one can consider stopping, but not without careful follow-up on over the long term. I would think I would leave that decision probably in the hands of an a hepatologist or infectious diseases physician with some experience.
Yeah, I agree. And then sort of following on from what you were mentioning, Salam Bukhali, I think, is asking, what's your experience with a functional cure? So I guess maybe outside of the HIV co-infected people, have you, I guess, is that something that you're seeing? I mean, there's obviously a percentage of people who lose their surface antigen, each year or so.
Yeah, it's low. For the HIV group, it's very low. We don't see a lot of seroconversions. No, I can't really say that I've managed enough patients to have a real good feel for this, and also testing them again. We don't routinely continue to test surface antigens and to see seroconversion. We discontinue treatment in these patients and rather look for complications and do proper surveillance for fibrosis and viral load management.
Yeah.
So I can't really with confidence give you an answer to that.
Sure. No, I agree. And then just a last question from Paul Marisani asking, so you've covered the surface antigen among pregnant women. She's just asking if it's positive in a pregnant woman, what other tests do you send? Is it the standard ones that you do, like hepatitis B viral load, ALT, AST? Was there any difference in pregnant women in terms of
No,
testing?
I would definitely just do those. If you can only do an ALT and not a viral load, that's also good. If the ALT is raised, you would treat your patients. The S antigen, obviously, even if you can't do the ALT or not your S antigen, your E antigen, very important. Because remember, your E antigen is a surrogate for viral load. So even if you can't do the viral load, do the E antigen. And if that's positive, then that's also indication for treatment. In the absence of a viral load. And really, I mean, if cost is a major issue in your clinic or in your environment, I would give the viral load a miss and just do the antigen and start treatment if that's positive.
Yeah. Yeah, thank you so much, Jantjie. I mean, that really is an incredible overview. It's one of these things that we all encounter so often, but it's a subtle and difficult condition because it's so many different phases to it, and treatment differs according to subgroups and things. You've really done an incredible overview of a really complicated topic, and thank you. I mean, we've had over 200 people attend, and there's the chat is full of great comments, which is always a really good sign. So really appreciate your time, and I think. We're all going to go back to this. So just to reassure those on the group, we do record them. Jantjie's kindly agreed to this being recorded as well. So we'll put it up on our YouTube channel, which I've put a link in the chat. It usually follows about a week or so later, once I've had a time to edit the beginning and end, just to cut off the tail on the entry. We'll put it up there. So it will be available, and you can rewatch Jantjie's great pills of wisdom afterwards. But thank you again, Jantjie. Hugely appreciate it.
Jeremy. Thanks, Jeremy, for the opportunity. Just a last word. I think the disease should be managed in primary care. It's an infectious disease before it becomes a liver disease. So we should prevent the liver disease by treating it adequately in primary care.
Yeah.
Thanks.